Let's turn our attention to the symptomatic patient. And unfortunately, this particular virus appears to have a high incidence or prevalence of patients who are asymptomatic yet infected. And until we can test everybody, which unfortunately is not possible today, the only way for us then to contain this virus is to make the assumption that the young people, even though asymptomatic, are positive. And only by doing so could those who are asymptomatic and positive and don't know it prevent the spread. So I wanted to make sure that everybody understood the word asymptomatic did not mean non-infected. Quite the contrary, we need to emphasize that a large proportion of patients are infected but have no symptoms and therefore can be the spreaders. But let us turn our attention to the symptomatic patient. And by that, I mean the patient that has the feeling of flu-like symptoms and who has a real important need to reduce their viral load. And the reason for that is we need these patients to recover and not progress to red. So these are the patients we call orange. And very much like the asymptomatic patient, need to self-isolate inside their homes, but require supportive care. They should, and I emphasize this, avoid home remedies, which we'll talk to a little bit as we proceed through these symptomatic patients who are managed at home because of the danger of so-called home remedies. It is important for these patients to know when they should reach out to their physician, and in fact, when they should be hospitalized even, because the onset of pneumonia from orange to red could be very rapid, and from red to on a ventilator could be extremely rapid. The other issue that I want to discuss with regard to the symptomatic patient is what drugs are on the market today that are repurposed for this disease. And then finally, the opportunity, as I said, for us to avoid the fatalities of these patients or reduce the fatalities of the patient who go into the red phase and who have this severe lung damage and who are hospitalized. It is clearly the goal to take a patient from red back to orange and to prevent a patient from orange becoming red. So let's start a little bit on these patients who are symptomatic and the questions that they need to understand. First of all, let me just revisit again the difference between orange and red and how a symptomatic patient gets infected through the nose, through the mouth, through the eyes, through the mucous membranes into the lungs. And once into the lungs, these viruses attach to the ACE receptor. And once in the ACE receptor, it starts infecting the alveolar cell. You will see this alveolar macrophage, and we will, over the next few series, talk a little bit more detail about what is this alveolar macrophage, which I label as M2, and what's it doing there. This is your normal macrophages that cleans up what's inside your lung. And these mild to moderate patients have some level of infection in the lung, but not overwhelmed. This ACE receptor is here to protect the lung with mucus, and the surfactant layer is a protective layer of the lung so that the oxygen can be passed from the lung to the blood vessels and to the rest of the body. This is the alveolus. This is what we call the alveolar sac, and this is what happens in the infected patient. So we begin to understand the basis of this infection and how it occurs in the lung. So what are the symptoms? Well, I say follow the ACE receptor. And this receptor sits at the base of the tongue, in the nose, and because it sits at the back of the tongue and the nose, there are now reports of loss of taste and smell. So that could be a symptom of an infection. a positive COVID infection. The receptors are in the alveoli of the lung, and that's why a dry cough, which actually goes all the way on to difficulty in breathing, with the respiratory rate which is higher, which we'll get into. The ACE receptors are in the GI tract. So diarrhea and stomach cramps could be a symptom. And then they are in the blood vessels. And patients with hypertension are higher risk of this because there's higher exposure of ACE receptors. And then finally, these ACE receptors are in the what are called the immune cells themselves. And there's even a backdoor to the immune cells where the virus has figured out a way how to actually evade the immune cells or kill the immune cells. But the body fights back as you get this infection and the secondary infection, and you have a temperature. So if you look at the what happens in patients with these symptomatic infections, you could have loss of taste and smell, you could have a dry cough, diarrhea, hypertension, and high temperature. These are clear symptoms that you may have an infection and need testing. So what happens when you need this testing and you know you are positive? How do you know that you have to go into the hospital? What requires hospitalization? Well, as I said, this is a very dangerous disease, and you really need to understand how rapidly this can progress if you're not careful. So a positive COVID test could be asymptomatic, or you could be just mild to moderate. Presence of a high fever clearly begins a demonstration that is pneumonia occurring, is a secondary infection occurring, which then requires hospitalization for you to go and see your physician. A high respiratory rate, and what we mean by that, as your lungs have much more difficulty in terms of inflammation and fibrosis and fluid, the passage of oxygen requires much more of a rate. The normal rate, 8 to 12, goes to 20. So the counting of your respiratory rate, the need to take much more breaths more rapidly in order for you to feel comfortable is not a good sign saying that you need to be in hospitalization. The oxygen saturation, where you can measure the oxygen saturation from your blood levels, these are all a consequence of now the lung becoming affected, and a chest X-ray that shows pneumonia. And then finally, 100% of patients with a positive COVID-19 infection have this appearance on CT scans of a ground glass effect and fibrosis that occurs. While this is a test that absolutely confirms the positiveness of severe COVID, it's not recommended for everybody because the radiation effect of a CT scan in its own right is not safe. So the medical signs that require a patient that is symptomatic in this orange state to be very aware that could go very rapidly to the red state, that with a high respiratory rate, a low oxygen saturation, evidence of an infection, difficulty in breathing, these patients need to very quickly get to the hospital. So in this instance of a patient in this orange state, what have we learned from SARS in 2003? And that's been at least the blessing of some level of experience that SARS 2003 and SARS-CoV-2 have the commonality of the fact that it's an ACE receptor and that the virus in its replication stage has some of the same characteristics. And we talked about how chloroquine and hydroxychloroquine and now azithromycin have been talked about with regard to opportunities to reduce the replication. Remdesivir, Kaletra, these are two antiviral drugs which we'll talk about. And there's a whole slew of other drugs, methotrexate, amiodarone, and the question, which is much more complex, about whether one should be on an ACE inhibitor or an ARB inhibitor for hypertension. These are questions that, frankly, we do not really have full answers. These are questions that require clinical trials. These are questions that require clinical understanding at the clinical practice level. But in times of desperation, it is clear doctors, hospitals, and even patients themselves are taking on these drugs that are on the market for their own use. So let's talk about some of them. Chloroquine, hydroxychloroquine, Plaquenil. They're basically the same chemical structure. And this is chloroquine, which is discovered for malaria. So it's an old anti-malarial drug. And then the hydroxychloroquine, which is a derivative of the chloroquine, was developed so that you could have a better solubility. And it appears to have a higher efficacy. I say the word appears because we're not sure even of the true efficacy of this until we do the clinical trial. So there's chloroquine, hydroxychloroquine, and the trademark name of hydroxychloroquine is called Plaquenil. There's been a very small study that says if you combine chloroquine, hydroxychloroquine with this antibiotic, there seems to be even a synergistic effect. There may be some evidence that this is an anti-inflammatory mechanism, but it's really unclear how and why this combination works, if it does. But before we move on from this chloroquine story, I do want to emphasize that this drug, hydroxychloroquine or Plaquenil, is actually approved for patients with lupus and patients with rheumatoid arthritis. So it is very important for us to understand in the community that these drugs are in great need for patients who really do need them on a day-to-day basis. So luckily or happily, I think the pharmaceutical companies are now increasing the manufacture of these two drugs so that we do not run out of supply for those who really need it in its approved state. What is the theories of how hydroxychloroquine works? Well, one, it actually affects this ACE receptor through a thing called glycosylation. Two, it affects the fusion of the virus into the membrane because of the pH. It changes the pH. And three, it actually affects the endosomal packaging as well as this thing called RNA polymerase. So these are the theoretical reasons of why these findings prompted the early testing of chloroquine for COVID-19. And with regard to the effectiveness, well, from China there were conflicting results. On the one hand, there were some results that said it's effective. On the other hand, when they did a randomized study, they showed no difference. So this is why it's important for us to understand that it is correct for the FDA to say we need randomized clinical trials with this against placebo. There's been a report, widely touted report from France, that only in 6 patients, when you do combination of chloroquine and zithromycin by day 3, the viral load was significantly decreased compared to controls. This looks promising, it's the best way I could say, but again, until you do the clinical trials, we won't know. Having said that, one has to be super careful because one of the problems with hydroxychloroquine in its side effects is arrhythmia, which is a rhythm of the heart, which could in itself could be fatal. When combined with azithromycin, that arrhythmia complication increases because both could have such an effect. Before I go beyond just the chloroquine, this is the danger of, I believe, television, of an uninformed audience. What was remarkable when the chloroquine phosphate idea came out, there was a run on chloroquine phosphate that was used to clean fish tanks. And people would be taking this chloroquine phosphate in water and drinking it as if this would be a prevention for COVID-19. And sadly, a person died. So a great warning, no home remedies, and chloroquine phosphate is not fit for human consumption. Another warning, as I just shared with you, that the combination of hydroxychloroquine and azithromycin raises the risk of heart irregularities. So it's not without risk, even though there may be a desperate need to try and self-remedy. If you are going to go on these two drugs, you should do it with the coverage of a physician inside a clinical trial. Having said all of that, amidst these controversies, FDA has now issued an emergency authorization allowing this hydroxychloroquine to be used in the treatment of COVID-19. So I leave you with the hydroxychloroquine that it is proved under these emergency conditions, but is still not without risks and has to be fully proven. Which then takes us to the next set of drugs called remdesivir, which some of you may have heard. What remdesivir is an antiviral drug that was developed by Gilead for Ebola. And it is what we call a nucleotide analog. In layman's terms, it's here to decrease the viral replication by tricking the virus into creating a version inside the machinery which inhibits the replication. So there's complex science here called RNA-dependent RNA polymerases inside the machinery, and that's what remdesivir potentially does. And also this proofreading capability of this amazing virus, it actually may inhibit that. There is good science about why this would work. Having said that, again, it's unproven until the clinical trials are completed, and there's a large remdesivir clinical trial going on. The Solidarity trial is a trial where all the known antivirals, such as remdesivir, such as Kaletra, which is an anti-HIV drug, as well as the antivirals, are all being tested. And that brings us now to Kaletra and interferon beta. So Kaletra is a combination of two molecules or two chemical agents, one called lopinavir and one called ritonavir. And these molecules are really antiretrovirals. It's a little complicated because HIV is a different kind of virus, what we call a retrovirus, and they're used in HIV. The thought process being here that these drugs, while effective against HIV, may be effective against COVID virus by inhibiting these things inside the cell, again through the machinery called these proteases. We don't know this yet. These drugs, however, are toxic, have severe side effects, including things like pancreatitis. Again, should only be considered inside the world of clinical trials. While I've summarized in a very limited fashion some of the well-known drugs that could be repurposed, there are many being considered. Some like amiodarone, which is used for arrhythmias, they may also have a role in preventing fusion. And then there's this whole discussion about ACE inhibitors versus ARB inhibitors. What do I mean by that? Patients now on antihypertensives, there's a drug that inhibits ACE. ACE is separate from ACE2. ACE2 is protective of the lungs. ACE is injurious to the lungs. ACE2, however, is where the spike protein binds. So should you be having an ACE inhibitor or an ARB inhibitor with regard to these two receptors? Should you be on these drugs at all? Should you change one for the other? The answer to this is all unknown at this point. These are interesting scientific questions, and the recommendations now from the American Heart Cardiology Associations are, in fact, you should not make any changes at this point. So these are complex discussions about repurposing old drugs, which says that there are treatments for drugs that could affect the machinery, the fusion, or the endosomal packaging, all for the purpose of reducing the viral load inside the infected cell by the virus, so that these patients don't go from orange to red. As I said before, the inflection point for us is to get to the vaccine. On the other hand, there are treatments on the horizon, which we'll speak to, that can even treat these symptomatic patients before they have the cytokine storm, so that we can actually kill the factory. And that is potentially the use of NK cells or the use of IL-15. But that again should be a subject of clinical trials in the future. So with that, we will then move on next to the critical patient.